it's my pleasure to introduce the next speaker, Dr. Mustafa Alttahir. Dr. Mustafa will talk to us about the surgical treatment. Dr. Mustafa is an orthopedic surgeon. He arrived in Australia at 14 years of age as a refugee from Iraq and attended Fairfield High School for 3 years before completing his undergraduate at the University of New South Wales from 2003 to 2008. He completed the Australian Orthopedic Association training in multiple centres of New South Wales and ACT and passed his fellowship exam in 2018. He subsequently completed subspecialty in surgical training and research fellowship at the International Bone Research Association Fellowship in Switzerland and Spain, Prince of Wales Fellowship in Sydney, New South Wales, and Macquarie University Fellowship, Sydney, New South Wales. His main area of interest is lower limb arthroplasty, foot and ankle surgery, lower and upper limb deformity correction, trauma surgery, and osseointegration surgery with an implant and osteotomy guide design. So please welcome me, let's welcome all Dr. Mustafa Alttahir for the presentation.
Thanks everyone for being here on a Saturday, giving up your valuable time. So I think there's going to be a lot of overlap with the talks that were given already, Dr. Haddad and Dr. Al-Musawi. So I work out of Macquarie University Hospital, Norwest Private Hospital, Campbelltown Private Hospital, and East Sydney Private Hospital. I do have some financial disclosures. I do some design work for Osseointegration International here locally as well. So that was already mentioned. I'll skip that slide. Why hip and knee arthritis in the setting of a GP conference? Obviously, it's a very common presentation to general practice, and it's increasingly prevalent as well in young patients. And I'll try and focus my talk on how to manage this in younger patients as opposed to sort of older patients, where I think most of you are quite well aware of the treatment options. So, you know, the approach that I use is more of a limb reconstruction approach. What does limb reconstruction mean? It's treating the problem as a biomechanical problem. So Dr. Haddad touched on it, assessing alignment, deformity in the joints, looking at joint orientation, trying to restore native anatomy and load distribution. And so that involves a lot of offloading procedures, especially in young patients, to try and avoid getting to the arthroplasty stage. Just to mention, we do have a no out-of-pocket joint replacement program at a couple of hospitals that I work at. So if patients are privately insured, they will be no out-of-pocket for their joint replacement surgery. So what are we talking in terms of arthritic knees? So anyone who's under 55, we know from the Australian Joint Registry database that their outcome from a joint replacement point of view, especially in knee arthritis, is they have a higher revision rate. So those patients, we try and avoid doing joint replacement even in end-stage arthritis if we can. Now the etiology has already been, I think, mentioned, so I might skip that, as well as the pathophysiology. In terms of investigation, the number one thing that I think I would emphasize is the importance of x-rays. So in the general practice setting, I think the most important investigation to get is a weight-bearing x-ray, whether it's a pelvis, hips, knees, foot and ankle, hindfoot alignment views. The weight-bearing image is of utmost importance, whereas, you know, the MRI can give you a lot of information when there's intra-articular pathology that's a bit obscure. So if you've got a normal x-ray, if you've got an abnormal x-ray, the x-ray is pretty much what you really need. And so there are some advanced modalities in terms of x-ray. The EOS scan, which is based on a Nobel Prize winning concept, but it gives you a lot of information from a joint alignment, leg length discrepancy, rotational profile, parameters that you get a report, and that report can actually outline a lot of things that you can interpret very, very easily. Are they varus valgus? Do they have a leg length discrepancy? Is there a rotational profile problem? And that can aid you in figuring out, do these patients have underlying misalignment that might benefit from our input. There is a weight-bearing X-ray that we have at Macquarie University Hospital as well, which has revolutionized our ability to look at so 3D modeling. I do a lot of 3D modeling. A lot of my deformity patients, we do real-time 3D modeling. They come in on 10 a.m. They have a CT scan. By 11, we've got a 3D model. We can go through it with them in real time in the clinic, and I can analyze their deformities and go through it and figure out if they need, and in real time as well, I can show you some videos of correcting, simulating corrections, figuring out if there is, especially in young patients, if they've got arthritic problems, if we can try and help them. Obviously, non-operative management options, everybody's spoken about that. I'll just mention offloading braces. There is a role for some offloading bracing in the setting of knee arthritis. If patients are varus or valgus, it can be poorly tolerated. No, it's not everyone's cup of tea, but in the patients who benefit from it, if they're young and they can use it, it might help them substantially while they're waiting for hyaluronic acid or corticosteroids or PRP to have an effect, and it might prolong the life of their joint in flare-ups to avoid going down the arthroplasty path. So when should you refer to an orthopedic surgeon? If there's failure of non-op management, persistent mechanical symptoms, patients who have significant alignment issues, and that's the key. So if you see a patient with alignment issue, even if they don't have advanced changes on X-ray, it is important to refer them early, because you miss the opportunity to alter the natural history or the progression of their disease. If they have severe varus or valgus, even as a 20-year-old and they're already getting some symptoms, there is a role for us to see them and counsel them about the options. Because if you wait until they're 55 or 60, or sometimes patellofemoral arthritis in early 40s, they present with advanced patellofemoral arthritis, you've missed the boat. You're talking to them about partial joint replacement, and that's something that we can sometimes significantly modify. So what is joint preservation surgery? We try and offload, realign, and stabilize if they've got concomitant ligament problems, and repair any things like meniscus or labrum, or ligaments around the ankle if there is instability, to try and prevent that from causing further deterioration. So the aim is to preserve function. One thing I'd say is arthroscopic meniscectomies are done far too often. They're not joint-preserving surgery. They're a waste of time. All this triple-blinded randomized control trials are showing now that arthroscopic meniscectomy actually leads to more advanced arthritis. And so patients really shouldn't have clean-up surgery for their knees. That's not a thing in 2026. So what do we do for those patients? I mean, if they present with medial compartment arthritis, they have varus malalignment. I'll focus on surgical treatment now. So high tibial osteotomy, that is a treatment that offloads. So if your medial compartment's bad, you take the pressure and put it in the lateral compartment. So the contraindication is if it's multi-compartment arthritis, then it's not going to work. So if somebody presents with varus, so they're bow-legged, and they have medial joint line pain, and they're young, there is a role for this treatment. Now, this is a video of the modeling. I don't know if it's going to run, but that's what I do in my spare time. I don't know is there a way to get the videos to run? Do you have a mouse, or is there a mouse? There is. It's running now. Okay. So that's what we do. You get a CT scan, you do a deformity analysis, you simulate the correction, and then you plan a patient-specific guide. We 3D print it locally. We've got a printer here, and then we can use it to accurately correct deformity. You can see this is a young gentleman. He's 51. He's got advanced medial compartment changes. He's got significant varus alignment. So pre and post, as you can see here, there's varus alignment. So the mechanical axis goes through the medial compartment where the wear is, and post-surgery it goes through Fujisawa's point, which is the lateral compartment, and he's had that correction. It helps prolong the life of his knee, and that's the plates put on, and then we can design some 3D printed guides based on that, so we can do accurate deformity correction. I might skip these because they can go on. So this is a patient who's 38. She presented with anorexia, medial hemicondyle collapse. So that's an extreme example, and she'd had, arthritis, septic arthritis shoulder, severe Charcot-neuropathy of the foot, and hemicondyle collapse here bilaterally. So that's a very complex problem. She's got pain, and she was an amputee. So we did a hemicondyle elevation, and that's very difficult to do without things like patient-specific guide. So we've elevated that, put some bone graft in here, and then you can see her sort of walking afterwards. So she's a bilateral amputee because of the Charcot-neuropathy, but at 38, she's still running, jumping, doing high-impact activity in sports. But you can see the deformity is corrected and her mechanical access is restored on that side. And she's got bilateral osseointegration implants as well. The other option is for valgus, which is knock knee patients. If their lateral compartment's worn out, you take pressure off the lateral compartment and you put it on the medial compartment. That's done on the femoral side. So for patients who've got advanced patellofemoral disease, it also helps them, but it doesn't cure the patellofemoral arthritis. So often, if they've got single compartment involvement, we can use this sort of treatment. This is a patient of mine as well who had valgus arthritis. She'd had 4 arthroscopies, no pain relief. And she presented, I said to her, it's a waste of time doing arthroscopies on valgus, varus aligned joints with overload of a compartment. So we did a distal femoral osteotomy. You can see her mechanical access now goes through center, and also did a tibial tubercle osteotomy, lateral release, and corrected her patellofemoral tracking. So at 40-something, she's now going to avoid hopefully needing a joint replacement anytime soon. And that's putting a plate on, designing the guide, and doing the surgery. I'll skip there. So the other main part is patellofemoral alignment issues. So it's a very common presentation. These are the patients that, if not picked up in their late teens, early 20s, they've got dislocations or maltracking patella. It's really important to pick them up very early. Once they start having cartilage problems, you've missed the boat. So if they've got anterior knee pain, they've got instability, maltracking, issues with the anatomy of the patellofemoral joint, they need to be seen early. So there's no point in waiting until they're 35, 40, 45, because then I'm talking to them about partial joint replacement, which is not an ideal solution. So patellofemoral maltracking is multifactorial. You've got femoral anteversion, trochlear dysplasia, patella dysplasia, patella alta, lateralized tubercle, valgus alignment. If they've had a dislocation, they get an MPFL rupture, external tibial torsion. So rotational alignment, malalignment in any form, and then you combine that with ligament laxity, and it makes it quite sort of severe. You can see how far the patella is sitting, how high and lateral in this patient, and this is a rotational profile assessment. So you can see the increased femoral anteversion. The leg internally rotates in a prone position significantly, and it doesn't really externally rotate. So these patients would benefit from, so this is a 3D modeling. We check the rotational profile, check the angle, check their tibial tubercle to trochlear groove distance, and then I can do femoral derotation, tibial tubercle osteotomy, valgus correction for these patients, and prevent them from getting to the point where there is advanced arthritis. So this is sort of what we look at, all the parameters. This is an example. You can... let's go back. So this is a young lady. If the video plays, you'll see maltracking. That's a shame. Can you? Yes. So you can see her kneecap basically jumps, and so that is a very extreme example of a maltracking patella. And then once we correct that with a tibial tubercle osteotomy, that will disappear. This is an in-toeing patient, so that's a sign of increased femoral anteversion, and so she's got her foot pointing inwards as she walks, and that's a very clear sign that she's going to end up with patellofemoral arthritis issues. Ignore the sling that I'm in that video. So that's what we did. bilateral femoral derotation osteotomy. That can be done through a keyhole approach, tibial tubercle osteotomy as well, lateral release, and corrected the misalignment. Hopefully that will prevent her from developing arthritis. There's also, we can do cartilage transplant, so we can get the whole of a distal femur, the whole of a talus, the whole of, any part of the body that has cartilage, and then fresh piece of bone with the cartilage, and take a piece and transfer it if we've got focal chondral pathology in young patients. So that is an option. It's an allograft transplant, and basically you take it from a donor, you create a hollow, and then you basically transfer that bone plug directly into the area that you need to fill. Joint replacement, there is options for partial or total. So partial is for patients who've got unicompartmental arthritis. They're lower demand, so offloading surgery is not going to be necessary for them, and we can do patellofemoral, lateral, or medial unicompartmental arthritis. That's good because you avoid changing the feel of their joint entirely. And then when I do total knees nowadays, we use a robotic-assisted approach. So this device, it's made a night and day difference in our ability to do knee replacements. So accuracy, looking at alignment, looking at a faster operation, less theatre time, and less pain issues for patients afterwards, and they get going much faster. So it's got a robotic arm, and basically comes in, we get a whole lot of parameters that I otherwise wouldn't sort of see used by feel. So, 0.5 of a degree, 0.5 of a millimeter, we check all these parameters, we map them, and then we get a graph, and then we can use that to do our deformity correction, realignment very accurately. I might skip that video. I'll just mention a couple of other things. Hip arthritis, very briefly. So there is an option. You're all well aware of patients who present with groin pain as opposed to greater trochanteric pain or buttock pain. The pathology is different, but patients who've got hip OA, groin pain is the primary symptom. Night pain indicates advanced disease. Doing surgery now, we do surgical planning using 3D planning of their problem with some x-rays that look at flexion, extension, their spine, because that has an influence on dislocation risk. And so we do that planning, and we can do an anterior approach, minimally invasive hip replacement, which in the future, very near future, we'll use the ROSA robot to do the hip replacement surgery as well. And then we can restore leg length offset and center of rotation. This is for young patients, so resurfacing of the hip joint as opposed to a complete hip replacement. This is an implant that's been released recently, and I think it will revolutionize treatment for young patients with hip arthritis. As opposed to having the entire bone stock taken out, you can just resurface the joint with ceramic on ceramic. I think it will revolutionize young patient hip arthritis treatment. I might stop here because there's a lot more to cover. Maybe next talk. Thank you.